Hi everybody, I'm Dr. Sean Mondu, and I'm the CEO and founder of Lift Healthcare, and I'd like to introduce you to the MD Dashboard. You know, the best performers in our society use data from their practice sessions and their performance sessions to inform their improvement. The concert pianists, the elite athletes, the Olympians all do this very reliably. Paradoxically, 7 years ago, when I finished my medical training, was the last time I received dedicated feedback on my practice for my improvement. And this is a problem. I think we can use the millions of data points that we generate in healthcare every single day to improve the practice of our clinicians and our hospital experience. At Lift Healthcare, we've created this MD Dashboard that really provides physicians feedback on 3 focused areas. 1 is quality and safety, 2 is care efficiency, and 3 is the cost of the care that they provide. We think that without this data, it's really difficult to ask systems to improve, especially clinicians. And we've deployed innovative care strategies, innovative data extraction strategies, and evidence-based methods to change the quality of care and to nudge behavior towards improved outcomes for patients. So the way it works is we work with hospitals to extract data. This data is sent into our secure cloud-based platform, and then every physician gets a login and username password to see their data indexed anonymously relative to their peers. This is a huge sector with a ton of potential. It is estimated that in the US, there's $8 billion USD in physician inefficiency alone in the United States. And this sector is in crisis. We think that over the course of the next few months, the next few years, hospitals are going to be looking for new modalities to improve the quality of care that they provide at a reduced cost. And this is an essential strategy for that. We work on a subscription as a service model and charge hospitals anywhere between $1 to $3 per physician per day, which is a very modest cost for the kind of insights that they're going to get for this work. And we have consulting fees on top of that. So we have 2 current clients that we use in the sector that are using our service, I should say. St. Joe's Healthcare and Niagara Health, but we have a ton of interest, 4, 5, 6 other hospitals right now that we're in active discussions around using our technology. We have a great group of founders and advisors that we feel give us the skill sets that we need to be successful within the space, and our pillar of business lines have very favorably reviewed our application. So we think important decisions demand better data, and we think this is the future of healthcare.
Thank you, Sean. That was a very interesting presentation. If I can ask, who would be the main purchaser or client? Would it be the hospital admin? Would it be the doctors? Who'd be the users?
So the buyer is the hospital. The user is both. So the user is both the clinician and the hospital. We have to sell to the custodian of data, and that is the hospital. And so most physicians don't have access to the EMR themselves as a data custodian and aren't able to filter that data. So our primary sell is to the institution. So obviously we know that we can nudge physician behavior, and that can have some benefits from an institutional perspective. But on the other side, hospitals are really excited to get data that they're not getting at all right now. And so we know, we've done some data modeling with some of our prospective clients that definitely shows that although there is an improvement that we can see from a clinician perspective in this, there's also substantial cost savings and quality of care implications for the hospital as well. So that sale is not so difficult to make.
And just as a follow-up, I can understand, it's very clear to me like how a hospital would be interested, as you know, the focus, as you said, on efficiency is huge. What would the individual practitioner's interest be in this?
Well, it's interesting, you know, we're raised in medicine on this culture of feedback. So you go through, 4 years of medical school, and every shift, every procedure, there's somebody who's saying, you should have done this, you should have done that, this is how you could get better, this is how this is the pathway to becoming a full-fledged physician, essentially. And then you do 5 years of residency with the same thing, sometimes with a fellowship. So you're 9, 10 years of like regular feedback. And I'm not kidding when I say, the second you become a staff physician, it all ends. Nobody's providing you with any feedback. And so we have this group of physicians, especially newer grads, that are saying, where do I sit? Like, where do I sit in my peers? How is the quality of care I'm providing? Am I a safe clinician? And for me, the thing that rattled me a little bit is I used to work at Starbucks before I was in medical school. I got more feedback on my latte making than I do on my clinical practice. That's a problem, right? We need to be able to provide clinicians with real insights about the care that they're providing, and we're not doing that yet.
how do you deal with the perception that, feedback is criticism, right? And, in my work with physicians, there is often a reluctance to get feedback because it is perceived as criticism.
Yeah, so I think there's two spaces that we've relied on. The first is that when we deployed this locally at our own institution, they kind of expected me to be standing in the corner of the room during their histories with a clipboard and writing things down. And it's human nature to have some antibodies towards that initial deployment. I think we should expect that and should welcome it as part of our deployment strategy. But really what was interesting is after a few months of getting the data, physicians felt significantly less stressed about this. And we've done 3 research projects now that are published in the medical literature around the adoptability of this kind of a practice and information. And so we know kind of the psychology that plays in this. We also have colleagues that have done this in Alberta as well that are part of our advisory group, and so can see where this goes. But I would say the message that resonates the most with our clinicians is the example around elite athletes. Usain Bolt isn't seen as less of a runner because he's looking at his tapes. The Raptors would be crazy if they weren't looking at game tapes pre and post. This isn't punitive strategy. That's not how it's seen by elite athletes and performers. It's really seen as a tool that is necessary in pushing them to the next level. And that's our messaging to clinicians. Use this how you like, but we feel like this is an essential part of you guys just being as good as you possibly can be.
Do you see an opportunity, like in a for-profit healthcare system, is the entry point different than in a government-funded or socialized medical system?
I think it's probably a little easier. I think the risk tolerance in a private system is probably a little bit higher than it is here. We've placed our pricing model in a segment that makes us really palatable to the public market, but as we grow our market share in Canada, the goal would be to create such a practice database that then allows us to leapfrog into different tools, markets, ideas, but then also be a competitor in the US. The thing I didn't mention in all of this as an example is we're also able to compare hospitals on a really top-down methodology. So I can show Joe Brandt the operational efficiencies of St. Joe's if they become a client. And from each other, they can learn these strategies that other people are deploying that might be effective in improving their own flow, their own efficiencies. I know that data sharing isn't happening in a meaningful way in the US because it's a hyper-competitive environment. But this mediated, protected, secure cloud-based server data that allows hospitals to aggregate and compare information internally in a safe, secure, non-public way, to me has a lot of appeal for these organizations to say, how do we get better? How do we move in a better direction? Not to mention the fact that if you're better in the US, you advertise it and you get more clients and you can charge insurance premiums and you can do all these other things. So I think this kind of a tool is really amenable to a different environment, but I also see as a practitioner here the potential it has in our local state.
When the hospitals make decisions to purchase something, they often want to see a lot of data. You mentioned that you had a couple of studies, and
Yep.
Would you be able to tell us a bit more about that?
Yeah, so we have 3 studies that exist in really the emergency medicine literature, which is largely where we're deployed for the moment. The first is a best practice study that we ran with a large peer group in Canada that shows, what the strategy should be and how we should follow this kind of what we call audit and feedback deployment within clinicians. We don't call it a report card. We don't call it performance measurement. This is a term that's well validated in the literature, and it's part of the lingo that we discuss with clinicians. The second is one where we say, what is the data that's important to you as clinicians that you want to receive, and how did you want to get it, and what's the best way to do that, triangulated with all the other stuff that's happening in this sector. And so now we know quite clearly what physicians want from a data perspective and how to deliver it and how to get past that. The third paper that we did was an evaluation of reticence to engage with data. And we kind of mapped out all of the barriers to wanting to engage with data and now understand the kind of data fidelity we need, the high quality of data that we need, and the common arguments that come out from the group and how we can mitigate that as a company. From a results perspective, it's a little bit more challenging because in the last 2 years, there's probably been no worse time to roll out a practice change intervention and measure its impact. It's just been terrible. And so what do we go on? Well, our docs say, this is fantastic, I love this. Our leadership says, I've never had a physician feedback session where I'm actually providing them with quantitative data on their practice. It's always been, people like you, you're not getting any patient complaints, your work's good, and so keep up the good work. But this is fundamentally different. And then we're mapping out cost-saving measures for hospitals that they've not thought of or heard of. And so I know we're in a space that's not common. Do we need to do that work? Yes. Do we have groups like OBIO or EAHN or Can Health that want to engage in us to do those trials of success and impact? Yeah, but that's a perfect place for us to be in right now.
So in terms of the hospitals that you're working with currently, are any of them paying customers, or is this part of a research program?
Yeah, so they're all paying, both of the hospitals are paying customers now. We have a third quote out. I had 3 meetings this week with other hospitals in the area. We're very explicit about who we target. We're targeting hospitals that we don't feel have the outright capability of reproducing the tool until we have a critical mass, and then we're going to approach everybody. So it's kind of strategic at the moment. But yeah, our 2 clients right now are paying clients.
Okay. And how have you protected the technology?
So the code itself of the technology, it probably isn't protectable. Really, what's unique for us is that we're not a vendor coming into this space that doesn't have clinical experience, that hasn't done clinical trials, that doesn't know what it's like to be a clinician receiving feedback. Like, we know this space very well. We're published in this space. We're working in this space. But do we have a patent? No, because nothing's really patentable here. It's just the way we're looking at data. Are there competitors out there that may represent some element of a threat to us? Absolutely. But nobody in North America is working in the emergency medicine space. Nobody is in our space right now. Even well-established customers in Ontario have shirked to the outpatient environment. So what does that mean? Well, groups like psychiatry don't have access to this feedback. Groups like emergency medicine don't have access to this feedback. Surgical groups don't have access to this feedback. And that's the bulk of what happens in an institution. So we're going to be first to market in a lot of these sectors, I think. And we got to get cracking.
Sean, thank you very much for the presentation this morning and your time.
Yeah, thank you.
Thanks.